You're 18 years old, standing in your kitchen in a shirt that still has the tags on, phone in one hand, acceptance letter in the other. You got in. Nursing school. You screenshot the email 3 times just to make sure. You call your mom. You call your grandmother. You post about it. You feel like the hardest part is over. It is not over. It has not started. Welcome to your life as a nurse. The first week of class, a professor with a voice like a malfunctioning printer drops a pharmacology textbook on your desk. It is 900 pages. It is one of 6. She tells the class that if you think this is the hard part, you should leave now and spare everyone the trouble. 2 people actually leave. You stay because you already told everyone you were going to be a nurse, and you cannot face that conversation. Smart reasoning. By week 3, you are memorizing drug classifications at 2 in the morning, eating cereal that has gone soggy because you forgot it was there, and staring at the words mechanism of action until they stop looking like English. Anatomy and physiology, pharmacology, microbiology, pathophysiology. Your brain is a storage unit that someone keeps filling while refusing to remove anything. You are also learning to think differently than you have ever thought in your life. Nursing school does not ask you what the right answer is. It asks you which answer is most right, and all 4 options look correct, and you have to think like a nurse before you have ever been one. Fun preparation. Your first clinical rotation hits in year 2. You walk into a hospital unit behind a clinical instructor who moves like she was born in scrubs, and you are assigned one patient. 1. A 67-year-old woman with congestive heart failure, a urinary tract infection, and 4 IV drips running simultaneously. You have practiced on mannequins. You have practiced on plastic arms. None of that matters now because she is a real person looking at you with real eyes while you try to remember which hand you wash first. You check her wound. You listen to her lungs. You hear something that does not sound right, and you genuinely cannot tell if it is a crackle or a wheeze or if your stethoscope is broken. You document everything. It takes you 3 hours. An experienced nurse does this in 45 minutes. Your instructor says you did fine. Fine is not a compliment. Fine means you did not actively harm anyone. Congratulations. You pass your rotations: medical surgical, pediatrics, labor and delivery, psychiatric nursing. You spend 1 week on the psychiatric unit, and it changes how you look at people permanently. You spend a morning in labor and delivery and watch a birth, and you feel something you cannot name and probably should not try to. Then comes the NCLEX, the National Licensing Exam. The computerized adaptive test that adjusts in difficulty based on every answer you give. So the better you do, the harder it gets. And the worse you do, the easier it gets. And you cannot tell which is happening while you are sitting there sweating through your testing center chair. Minimum 75 questions, maximum 145. The exam stops when it statistically determines whether you are safe to practice. You will not know what that determination is when it stops. Some people finish in 75 questions and sit in their car for 20 minutes, completely unable to read their own emotional state. You pass. You are now a registered nurse. You have a license. You have a title. You have no actual idea what you are doing. Level 2 starts now. Most new graduate nurses land on a medical surgical floor. Med-surg. Hospitals send you there because it has the widest variety of conditions and the most stable patients. Stable being a relative term that will become a dark joke to you by month 4. Your orientation is 6 to 12 weeks. You get a preceptor, an experienced nurse who watches you, hands you responsibility gradually, and will absolutely tell you when something you just did was wrong. Week 1, you watch. Week 2, you start doing. By week 6, you are managing a full patient assignment. A full patient assignment is 5 or 6 patients. 5 or 6 people who all need medication administration, wound care, assessments, family updates, physician calls, discharge planning, and documentation, all at the same time. All with call lights going off the second you step out of one room toward another. You are making around $60,000 a year. You are working 3 12-hour shifts a week. That sounds manageable until you understand that a 12-hour shift is actually 13 or 14 hours because handoff runs long and your documentation is never finished when you think it will be. Your feet hurt in a way that is geologically significant. You buy compression socks. You buy the most expensive nursing shoes you can find. Your feet still hurt. You make a medication error in month 3. Not catastrophic. You gave something 30 minutes late because a patient in the next room was actively deteriorating and you had to prioritize. 30 minutes late is technically a medication error. You fill out an incident report. You feel terrible about it for a week. Your preceptor tells you that every nurse has incident reports, and anyone who says otherwise is lying. This helps slightly. You cry in your car after shifts, not because you are fragile, because you spent 13 hours carrying other people's worst days, and there is nowhere to put that weight when you walk outside. The 90-year-old man who held your hand and asked if he was going to be okay. You told him you were going to take good care of him. He died 3 hours later. You still think about what you should have said. You get faster. What took 3 hours in clinical now takes 90 minutes. You start to trust yourself. You walk into a room, and something tells you this patient looks different before you check a single number. That feeling has a name: clinical intuition. It saves lives. Year 2, you are not new anymore, and the floor knows it. You start thinking about where you want to go next. Level 3, you pick a specialty. After 2 or 3 years on med-surg, most nurses move somewhere more specific. Critical care, emergency, oncology, labor and delivery, pediatrics. You choose the ICU because during your clinical rotation in the ICU, the work felt most like the reason you started this whole thing. The ICU is not med-surg with better equipment. It is a different world entirely. Your patient ratio drops from 6 to 2, sometimes 1. But those 1 or 2 patients are the sickest people in the building. They are on ventilators. They are on continuous medication drips that require real-time titration, meaning you are adjusting doses by fractions of a milliliter based on second-to-second responses, because too much or too little of the wrong thing can kill someone in minutes. You go through ICU orientation, longer and more intense than your original training, learning hemodynamic monitoring and ventilator management and how to read a patient deteriorating before the monitor even knows what is happening. The monitor alarms after the problem. The nurse sees it coming. You earn your CCRN, your critical care certification, after 6 months of studying. You pass the first time. The certification means something to other ICU nurses. It means nothing to the patient trying to pull out their breathing tube at 3 in the morning because they are confused and terrified and do not understand why they cannot breathe on their own. You manage that moment with one hand on the tube, one reaching for the call light, your voice completely steady, because you have learned that your calm is contagious. Your panic would be, too. Sounds like a fun Tuesday. You are making $75,000 now, more with night and weekend differentials. You have stopped crying after every shift. You still cry sometimes. You have just learned which situations need the tears and which ones need you to process and move forward. 5 years in, you are thinking about what comes next. Level 4. The path splits here. Some nurses go back to school for a nurse practitioner degree. Some move into leadership. Both options cost you something. If you go the NP route, you return to school for a master's or doctorate while most people are still working full-time. Class on your days off. Clinical hours stacked on top of regular shifts. Papers, exams, competency evaluations. You are exhausted in a new way, different from floor nurse exhausted. Because floor nurse exhausted is everything at once, simultaneously. You pick a specialty. Family practice, acute care, psychiatric mental health. You finish. You sit your certification. You pass. You now have prescriptive authority. You can diagnose, order tests, and prescribe medication. You are not a physician, but you are practicing at a level that would be completely unrecognizable to the student who could not tell a crackle from a wheeze in her second year. Your salary jumps to $110,000, $130,000 a year. Patients schedule appointments specifically to see you. They call you their provider. If you go the leadership route instead, you become a charge nurse first. The charge nurse runs the unit for a given shift. You handle the staffing crisis when 2 nurses call out sick, and the house supervisor tells you to make it work with what you have. You solve problems that have no clean solution. Advocate for patients when physicians are being difficult, and absorb the anxiety of everyone around you while projecting the appearance of someone who has it under control. You become a nurse manager. You have your own unit. You are responsible for hiring, scheduling, performance management, budget, quality metrics, regulatory compliance. You are in meetings more than you are on the floor. You miss the floor constantly. You hold on to the fact that what you do in the meetings reaches every patient on the floor, even if you never see them. 20 years in, level 5. You cannot apply for it. Nobody gives it to you. It finds you after enough years of showing up. You walk onto any unit, and you know within 60 seconds whether it is a good day or a bad one, before a single person speaks. You can read a family in the first minute of meeting them, and know exactly how much they can hold and how to give them what they need without breaking them. You know things that cannot be put in a textbook. You have worked nights, days, weekends, holidays. You have missed birthdays and dinners and sat with strangers on the worst nights of their lives, and then driven home and done it again the next morning. New nurses come to you with the hard questions, not the clinical ones. How do you keep going after someone dies on your shift? How do you tell a family something they are not ready to hear? How do you stay present in a job that never stops asking you to carry other people's pain? You answer honestly because someone answered honestly for you when you were drowning in year 2, and it made all the difference. Medicine changed completely in the time you have been here. The technology, the protocols, the medications, the electronic records, the rapid response teams. You adapted to every single shift because nursing has never been about knowing everything. It has always been about knowing how to respond to what is in front of you with whatever you have right now. You are making $90,000 to $120,000, more if you stayed in a high-demand specialty. The money is not why you stayed. You know nurses who left for easier work and came back. You know nurses who swore they were finished and are still here a decade later. A 22-year-old nursing student is shadowing you today. She follows you into a patient room, watches your assessment, and you can see on her face exactly what you felt in your first clinical. The overwhelm, the determination, the expression of someone trying to memorize everything at once because she does not yet know which things matter most. After the room, you tell her one thing. The skill she needs most is not clinical. It is the ability to make a frightened person feel less frightened. Everything else can be learned. That one has to be practiced every day until it becomes who you are. She writes it down. You remember writing it down once too.